I will move on to Ashley Fox, RPN, CFN, and GPN-CC. I had to look up what those credentials were. I knew RPN, but the others I did not, and it's very impressive. Ashley is a registered practical nurse working as a community outreach coordinator and nurse case manager with Promise Home Care in the region of Waterloo. Her background in nursing includes community and home care, retirement and long-term care, addiction and mental health, palliative care settings, as well as various hospital settings. So really, Ashley knows healthcare from basically every lens. We're very lucky she was able to come because she has that experience. She's also an instructor with Conestoga College and runs a social media management agency. She's also former elected council member of the College of Nurses of Ontario, holding several positions from 2014 to 2021, including Vice President RPN. Her passion is working with seniors and helping clients navigate the Ontario healthcare system. So thank you, Ashley. I know you're very busy, so I'm so pleased that you could be here today. We'll turn it over to Ashley.
Never that busy. I can fit in the time. Thank you for inviting me to present to the group. So I'm representing in the home and community care. I'm going to start out with just a little bit of an explanation into the sector. It's more complex than the general public is aware, and there's a lot of terms that are used infrequently that gets changed regularly. So we'll start with the public funded system. It's qualified by HCCSS, the Home and Community Care Support Services, sorry. But you may have heard of them by their previous names in the past. They were formerly known as the LIN, part of the Local Health Integrated Network, and also formerly known as CCAC, Community Care Access Center. Their names have changed over time, but they are still providing home care services and qualifying the public sector for what you are able to get in the public funded home care system. Some services that are provided include personal support workers, nurses, allied health members of the team, such as physio, occupational therapy, and speech language pathology. And they also run various programs. So for example, rehabilitation programs, stroke recovery programs, and they are responsible for long-term care applications as well. Their contracted providers are home care agencies that bid on the services that are being provided. So there may be, at this time, multiple providers that are part of the circle of care to meet that care needs for that client. The private funded sector includes medical and non-medical businesses. And this can be a little confusing for some, but essentially there are non-medical businesses which are run by UCPs, PSWs, or general business owners. And they provide non-medical, so home support, cooking, laundry, and non-personal care services. They don't typically have a nurse that's on their team, so they stick to very home support type services. And then you have the medical industry as well, which is typically either providing nursing services or has a nursing supervisor or a nurse case manager on their team. These organizations can be part of large franchises, or they can be independently run. Then there's the third subsection of home and community care, which is the independent workers. There are a lot of personal support workers that are working independently and have found that that meets their need during the pandemic. There's also nurses, occupational therapists, and physiotherapists who have launched their own independent businesses. All three divisions in home care work in other parts of the sector, which can get confusing. For example, I work in the private sectors under the medical businesses. And so part of my role is to work in homes, which can include apartments and condos, hospitals, retirement and assisted living, as well as the long-term care sector. Typically, the public funded sector assists in all of those locations except for hospital and long-term care. Occupational health and safety challenges that we met in home care before the pandemic, our public funded services were already being stretched to the limit. This is due to funding restraints, the want to remain at home. 96% of seniors were surveyed before the pandemic and wanted to remain at home. And the complex needs that we're seeing in the community. It's no longer just a couple assistants with shower a couple times a week. Many people are requiring a lot more supports to remain at home, from medication reminders to medication administration. Many of our clientele do not have families that are nearby and really don't have a support structure in place. And we're going to see more of that as the years go on, I believe. The challenges that also occurred is that public funded hours during the pandemic were shifted to meet the priority need. We didn't know what to expect, and especially in the early stages of the pandemic. So respite hours were often cut or decreased because people were working from home and families were canceling their visits after outweighing the pros and cons of the pandemic and the risks that are required. Accessing nursing services since the pandemic has started has become quite an issue. We're going to go into some statistics near the end of the presentation, but essentially with the nursing shortages and the issues that are in play with wages between hospital, home care, long-term care, and retirement, the majority of nurses have moved on from the home care sector. Often nurses are asked to commute long kilometers during the day at minimal pay for those kilometers or none at all. They're asked to see multiple visits within a 12-hour shift, and many nurses found that the hospital was a more reliable employer at that time. Accessing PPE during the pandemic was, well, from my own experience, absolutely cumbersome. The public funded sector had access to the PPE supplies first, and often there was not-for-profit or PPE drives in the community that were only accessible to those public funded services. So if you are in private care like myself, scavenging for PPE, gowns, masks was difficult. It really was. My own personal experience, a friend of mine, her mom sews. At the time when gowns, you couldn't find them, she very nicely created at least 5 to 6 for me, just to make sure I was safe in that time period. There was no consistent testing or access to testing for home care. Long-term care and retirement were put in place with consistent guidelines based on how often they could test and how they could access. Home care was not addressed at that time. This made it difficult for staff that were going into retirement and long-term care homes because we had to meet their mandates. And unfortunately, with us not qualifying for certain testing, it was very, very difficult, especially to access those in community settings. The MOH guidelines and updates for the home care sector were increased for retirement and long-term care and regularly updated. The home care documentation, the last revised document is from May of 2021. Long-term care and retirement were increased their guidelines to increase their testing, the requirements for essential caregivers, and what requirements of third-party staff coming in. Home care had to adapt to their regulations as well as rely on what documentation we had as well, which unfortunately was very minimal from our provincial government. One of the other challenges we faced in home care is that in the circle of care, typically all of your care providers will come together to work in the patient's best interest. Since the pandemic started, there's been limited communication and limited access to services in the home care sector. For example, if a client of mine is admitted to hospital, we participate in a lot of conversation before they're discharged to make sure that they're safe to return home and that services are in place. The variety of communication has been delayed, either by access virtual or lack of staffing to be able to have that communication. And unfortunately, services are often delayed. This puts the majority of patients and clients in home care at risk. And what's different about this wave? So staff are getting sick more, and that's just a reality. Omicron is extremely contagious, so it's not surprising to hear that staff are becoming more sick on each part of the home care sector. The sector is becoming more proactive, though, on the PPE and on testing, and that's from their own direction and their own initiative. N95s were implemented in some of the public sector for some contracted providers on a query diagnosis based on their risk assessment, a confirmed positive, or just based on access. We did not have access to that in the initial part of the pandemic. The circle of care is working together now and starting to meet the needs of the patients. And this is welcomed with legislation for the essential caregivers, and homes are welcoming staff. In the initial part of the pandemic, long-term care and retirement immediately shut their doors based on legislation to home care access. And what they realized is that they can't manage those clients or those heavy complex care without home care's assistance. Some home care providers and some long-term care providers were also more accommodating than all of them together. So I can't say that it was the entire sector, but it was a big issue at the time. Access to rapid testing, retirement homes and long-term care homes are coming together with home care to make sure that they have access to testing as required. This is a big change because when we were trying to access our own testing, unfortunately, it was inconsistent, just based on, unfortunately, with the need for rapid testing and access in general. Another change that we've seen is burnout and mental health services. This is amongst all of our patients, their families, and the professional caregivers. As the pandemic goes on, I don't think this will be changing, so we do need to be able to access resources for them. Two states that will be very helpful for you in terms of statistics. So on January 24th, 2022, Home Care Ontario, the Association for Home Care, had posted a statement. Home care has lost an estimated 4,000 nurses since the beginning of the pandemic in home care. Prior to the pandemic, home care providers fulfilled requests for nursing care at 95% of the time. As of December 31st, 2021, that number has dropped to 56%. This means that home care providers are unable to effectively serve 5 out of 10 families who require nursing care. Nursing care might include wound care, chemotherapy, IV services, and services for those who have been discharged from hospital. This is real, life-altering consequences for our families and our patients. Happy to take any questions in regards to the home and community care sector, but thank you so much for having me.
Thank you, Ashley. I think that home and community care is a critical part of healthcare. It helps people live at home with dignity. People who don't want to go to long-term care can stay at home. People who need support with, a spouse or a child. It's just such a important part of our healthcare system. And it's one that I have noticed is the afterthought. And I hate to say it that way. But as you pointed out, there have been so many, there hasn't been an update. Did you say, I forget what you said, June of 2020? Is that when you said the last update was?
The last revised date that is on our documentation is May 2021.
May 2021, okay. Whereas I know a lot of other aspects of healthcare have updated since then and have adjusted things in light of Omicron. So it's certainly not seeming like it's at the forefront where it is so important to our whole entire healthcare system. So if anyone has questions, you are free to unmute yourself or ask them in the chat.
I have a question of Ashley, Krista. So thanks so much, Ashley. It's really interesting to hear your story and perspective on what's been happening. We're kind of advocates around looking closely at improved ventilation and also, N95s or better for everyone that comes into close contact with, suspected or COVID cases. I'm just wondering, have you seen any changes in improved ventilation, such as, standalone air purifiers, for example, or any other improvements, better awareness and education around ventilation and everybody wearing N95s? I'm wondering if you could expand on that a bit for me. Thanks.
No problem at all. So I haven't had any updates in regards to our clients or patients in regards to air filters. I know there has been significant education done to our clients in regards to wearing masks while the workers are in their homes. We've been asking families and staff to be able to do that. Our staff are automatically wearing one, but to be able to educate clients on the risk of having other workers in their homes. It's difficult because home care is such a varied sector. The retirement homes and long-term care homes have been putting in specific ventilation that's been provided by the government in directives. So any of our staff working in those parts of the sector have benefited from that, but in people's homes individually, no, I haven't noticed a change.
Okay, thank you.
There's one question from Mark Crofts commenting, I don't know if you saw it, Ashley, that you folks are amazing and we've relied on sector services, and it is true. I think everybody has been, knows someone who's benefited from the incoming. assistance in home care. It's a massively important service and under-resourced. So he asks, successive governments have studied, but other than tinkering with wages a bit, the same problems persist. What's the root barrier, do you think?
Unique industry. Part of the route would be the transportation. I can only speak for the urban population that I work in Kitchener-Waterloo. However, if you go out of town about 15 to 20 minutes, you're then considered rural. And having staff to access the rural areas, I live 45 minutes away from my urban sector, but I know some of my coworkers and we've joked when I've said, a 30-minute drive is nothing, and they don't understand. They think that's a little bit too far. So that's one of the issues I think that comes with play. It's really hard to discuss what a solution to that is, because home care is ultimately transportation. We're providing care in people's homes. But you've also mentioned, Mark, as well, in regards to the wages and looking at timing. There has been quite a bit of research done in various communities of how to establish workers that could do a small community subset, so be responsible for 3 or 4 homes for what their care needs are. And also the other reality is people are not qualifying for enough care. We know that their care needs are not being met. So we may have to just revolutionize, unfortunately, the entire industry of how that meets their care needs.
The 56% statistic is pretty disturbing, I guess, and that's quite recent with Omicron and everything else, I guess, and the loss of staffing that you described of 4,000 fewer nurses since the beginning of the pandemic, I think. I don't know. Is there a plan to, I guess, how do you address that? I guess I'm assuming some kind of triage, but I just, it must be very stressful for everyone. And so I just wondered if there were things happening and in that regard, and in terms of planning more community approaches or engaging volunteers or anything like that that's underway.
It's a very tough subset, because the nursing component in that statistic is legitly RN and RPN scope of practice that's required. Right. So a lot of those folks were requiring wound care assistance, the IVs, once they've been discharged from hospital, specific surgery, wound care. The home care industry, in terms of public funded, had developed clinics. So they had assumed that a clinic staffed for a 12-hour shift or 16 hours, that the person would come to them, which in an ideal world would be fantastic. But we know that, some surgeries, some procedures limit you for driving, limit you for transportation. So they were staffing clinic settings very well, but unfortunately, as the pandemic continues to evolve, we're recognizing that staffing agencies are also paying triple the wage. So a lot of nurses have been really enticed by that increased wage to do less work, less hours, and they've really been enticed in that sense. It's going to be difficult in terms of what a solution will be for that. I know there's lots of nursing associations that have been advocating quite strongly at the government level, but we haven't heard of any changes that'll be coming through yet.
I've got another question for you, Ashley. So we do have a Directive 5, for healthcare workers, where they actually have to do a risk assessment to determine whether or not they need to wear a respirator, an N95. And I'm just sort of thinking here, for home workers, home care workers, to figure out what the risk of exposure is and what kind of personal protective equipment they need, they probably won't know. They don't know if the person in the home is infectious, or they're they go into a number of different homes. So, and I'm also thinking with Directive 5, it really leaves it up in the air to the worker to make that decision. I'm just wondering if you had any thoughts on that or any comments on that.
Yes, so that's actually where a lot of the joint health and safety committees have come into play, especially in regards to the private sector and the public funded sector, which is where those N95s I had mentioned in the beginning, we are starting to see them being accessible to staff and being utilized, because the assessment was part of our ministry documentation as well. In that document that's revised in May, it does require us to do a risk assessment. However, does state in our directive, face shield and mask is the minimum protection, and then if their risk assessment deems it to have an N95. But you're absolutely right. The interpretation both by employees, employers, and the sector, the information is so vague that it could be misinterpreted.
Yeah, I guess if I just want to carry on with that, how do you know? And isn't it better to, inform all home care workers just to wear an N95, a fit tested N95? It seems long-winded and ambiguous to me, but thanks for that.
No worries. And I think to tie into that as well, part of the issue is the testing. As the testing requirements have changed, even accessibility for some of our patients, they don't qualify. Even though they're patient facing or they have services coming in, multiple providers, they're no longer testing that they qualify for PCR or rapids, which is a little confusing. I will have to give a shout out though to my retirement and long-term care sector. I know it's been very confusing for them with us coming in because their testing directives have been so different. So for example, in the summer, I was assisting a long-term care home with some staffing that they needed support with. And they were really concerned of when my last PCR was. And when I said, unfortunately, I can give you a date, it was extremely outdated. It had been based on my own symptom response. And they were just very pleasantly shocked that how home care was treated so differently from their sector, where they were testing twice a week at the time.
Great, thanks. So just in the chat box, I noticed Simon Smith actually put a bit in there about the Canadian standard for respiratory protective equipment and selection. And there is a section in the standard that really does take the guesswork out of choosing what kind of respirator you should wear. I don't know if you wanted to just quickly talk to that, Simon, if you don't mind.
Thanks so much. Thanks. Update to the standard in the late 2000s, post-SARS, taking in considerations from the SARS Commission. In particular, what we added in that standard was control banding based guidance. So use a semi-quantitative analysis of the level of hazard of the pathogen on the NIH scale, the generation level and the control levels or ventilation that's applied, each of those on a 1 to 4 scale, that goes into an algorithm and provides as an output a level of protection, which is equivalent to the assigned protection factor of a type of respirator. And that is something that then guides you to the appropriate protection. One key feature of it, it was designed originally to match the existing guidance that was generally out there. It is intended to be used when there isn't guidance, but it does fill gaps, and it takes into account ventilation. So whereas you might have general advice for an aerosol generating procedure to use filtering face piece N95 level, this guidance says that if the ventilation is poor, say you're working in a corridor or a patient room because there isn't enough facilities, it would recommend upgrading the level of protection in accordance with the poor ventilation. So it has a bit more flexibility that way. And IRSST, Health and Safety Research Organization in Quebec, has also created such guidance and has it available online. I'll put that in the link as well as a tool to use. CSA is going to be doing that shortly as well. So it may be useful. What the unfortunate thing is it has not been referenced by any of the health authorities that I'm aware of. None of the governments nor provincial agencies medical agencies have actually referenced this, but it was actually intended for use during a pandemic. But there we are. Thanks.
Thanks, Simon. And just to add to that, so on Monday, Workplace Health Without Borders are running a webinar on this particular thing on respiratory protective equipment, and Simon's going to be talking to that as well. And also Jen McDonald's going to be talking about a do-it-yourself fit check for respirators as well. So everybody's welcome to attend that, and I provided a link in the chat box as well. Did you want to say anything else, Val? Or
I see
Krista?
Nick Bono had his hand up. Nick Bono had his hand up, so we'll invite Nick to unmute.
Thanks. I just to kind of touch on what I guess Kevin had raised and Simon as well. It's Directive 1 is the directive that applies to home care. Directive 5 does not apply to home care. The updated Directive 1 says that you can be provided with a respirator that isn't fit tested, which is frustrating, but that the employers do have to make an effort to fit test. And I just wanted to share that we had some success early on with some of the home care employers that we where we have members, where because of the technical brief from Public Health Ontario, and the emphasis it puts on ventilation, given that people in home care, don't know what the ventilation is in their house or in the houses that they visit, that they need to be provided with fit tested respirators. And so we did have some success early on there, but for the sectors where ONA has members, it is the sector that is for both home care and public health, where the public health unit does community visits. We do see I would say the worst response around fit testing and provision of respirators, but the lack of ventilation and the obligations under Directive 1 should be sufficient for any unionized person to, either through a grievance or through the Health and Safety Committee, make sure that they have access to respirators and that the employer is going through the process of fit testing staff.
That's great information. Thank you.
Thanks, Nick.
And for those who are watching along, if you don't have the chat open, open up the chat. There have been lots of information put in there from CSA, linked to the CSA Standard Z94.4 to IRSST online tool for selection. Going back earlier, there were other things posted as well. So please be sure to look there. If anybody else has any more questions, please, this is your chance to ask questions, or if you are in any aspect of healthcare, then definitely share your experience.
There's also a little smiley face down the bottom of your screen there. And if you click that and you see reactions, you can raise your hand. So if you actually want to show yourself and ask a question, please do so. Thanks.
See Dorothy's question asking, what can we do? I think, Dorothy, I don't know if you wanted to clarify that further, but what can others do to help you folks get better protections, actually, was the question.
Yeah, it was mostly just thinking of if you're in a union, well, hopefully they're doing something. But I just heard today from the local newspaper where I had sent a letter to the editor and they want me to make a few corrections. I'm thinking, are there things that people can do like that? Other ways you're thinking that the experience of home care workers can get out there so that we're supporting the efforts to get you more protections.
Yeah, and if I can just add to that, Dorothy, thanks. I did put a link in the chat box here. So OCO have just finalised a fact sheet on respirators, and we kind of demonstrate how respirators are so much better than cloth masks and surgical masks. So for those of you who are actually trying to defend a position that you need to wear an N95 or better, or get workers to wear an N95 or better, you should have all of the answers in that fact sheet. So it's there for everybody's use, and hopefully you can make some changes with that if you need to. Thanks.
Kevin, did you say that's already in the chat or that it's on the website?
It's on our website, on the OK website, but I've also put the hyperlink in the chat box. So it says see new
Perfect.
OK fact sheet
Perfect.
on respirators.
Thank you so much.
I have a question that I guess Kevin's comments sparked in terms of would there be any feasibility to take an air cleaner? Like there's the ones that are sort of the size of, I don't know, a canister, you know, double pail of ice cream or something. There are a variety of sizes. It would have to be decent enough quality and air circulation to make a difference and not just be a token. But about taking that into work, or that part of offering home care is that the sort of making that on the checklist that a home needs to have one, I guess, in order for workers to come and be in such close contact.
I briefly saw Nick shaking his head no.
Yeah, he doesn't think that would fly.
I think just to add to that too, Val, you know, I remember, you know, making my own air purifier using the Corsi Rosenthal method, you know, going to Canadian Tire and buying their gear, the fans and the box fan and the filters that go on the side, and taking it to my little boy's school, and the principal actually accepting it and putting it in his classroom. And I'm just wondering, like with the long-term care homes, why can't people just make an air purifier and take it into their relative, you know, and to donate it? Is that something that people could do, Nick?
Well, yeah, I mean, but you know, the unions don't run the homes, unfortunately. So you know whether or not but I mean, it's interesting with long-term care because it's the resident's home, right? So you know, I would assume that if a resident you know had a family member or the resident themselves made a Corsi Rosenthal, you know, box that would be okay. I think the issue with air cleaners for people who do home visits is, you know, essentially you'd have to go in, you know, plug in the air cleaner, run it for 15 minutes to half an hour, you know, and, you know, for it to actually do its thing sufficiently for the, you know, the space. And then there's also the kind of health and safety issues of, you know, getting the air cleaner in and out. But yeah, you know, I hear what you're saying, Val. Some of them are not that big. You know, and even the Corsi Rosenthal boxes, there's ones now that are, you know, with the mini fans and smaller filters that seem to be quite effective. But you know, I think it's, you don't usually want PPE at the worker, but, you know, if for people who are doing these visits, you know, it's why wearing a fit tested respirator, you know, it's so important. Like you have no idea, you know, what the ventilation is, what the filtration is that they have in their furnace, you know, all that kind of stuff. You just don't know the answers to. And I mean, it's part of why we've been, you know, trying to get more guidance around, you know, but anyway, I don't work for OCAL. I should stop talking.
No,
Sorry.
we value that. That input's really great, Nick. Really appreciate that. We've got Mark in the chat box saying we were told that since the Corsi Rosenthal box is not CSA certified, it was not allowed in the workplace. No reason given, maybe fire risk. I know that in long-term care, acute care, different aspects of healthcare, they, in my experience, have been very strict in the past about everything having the CSA or ULC, which makes sense. And some have restricted if you can bring in portable air conditioners because they can't tolerate that extra demand on their system. So I know that has been a long-standing pre-pandemic issue, but the Corsi, well, as Val says in the chat box, they have been UL allowed because so there's no elevated risk. Because they are just literally a box fan connected to filters, there's no extra demand beyond what the fan might draw. Sometimes that could be miscommunication. I'm wondering. That's my assumption on what's happening, but I know that is within the sector something that's been a longstanding, and bringing in anything electronic or electric has been a longstanding challenge. And Nick, you brought up a great point about setting up the filter for the 15 to 30 minutes to have an impact. That makes for a challenge as well. I mean, this is a sector that I've all of healthcare is a sector that has been particularly challenged, but I've noticed that long-term care and community care both have their unique needs that aren't always considered first. The acute care hospitals are sometimes considered first, and then it trickles down. I've noticed the same thing with community medicine, so family doctors, that sort of thing. I'd really hoped to get a family doctor on, but again, unfortunately and understandably, everyone we reached out to was too busy at this time, so we're hoping to do that perhaps in March. And I agree, Nick, it would be interesting to hear from Dr. Pirzada about the air cleaner use. Having 6 to 10 year changes per hour is fabulous. That is just amazing when he said that. And I think Dorothy commented on that as well at the time. So if there's any other questions, I'll give it a few more seconds.
I have one more question for
Yeah.
Ashley, I guess, and for Nick. Well, just has there been more careful cohorting of the worker to only a small number of patients, so that it's, you know, that's kind of adhered to more strictly, that you have your flock and you only go to those 3 or 4 houses, although I know you did say sometimes it's 12. But anyways, I guess that's, I think, really critical to reduce everyone's risk, is to limit the interactions, right? But how do you do that reasonably? And at least are they dedicating, you know, that one nurse or a healthcare worker or PSW only works with specific, as opposed to sort of randomly sending people a different list every day?
You are correct. I did kind of imply, unfortunately, with the public funded sector, it depends on the hours. So in home care, sometimes there might be 1 hour, 2 hour, 3 hour clients. I know I could only speak for our organization. We have limited where our staff are going and tried to limit the number of people going into homes. Pre-pandemic, we were looking at about 2 to 3 because we were trying to, if anyone had a sick call, we were trying to have a backup plan, because there's often these clients have complex care plans and they need someone who knows their personality, their quirks, and what works within the home. Now we have been limiting it to 1 to 2, and depending on if they're working in facility versus working in home, we have also tried to mitigate that as well, just based on the risks of homes going into outbreak. For staff that are working in outbreak situations, they are in the outbreak situation. They're not moving to other facilities or other homes, but we have been very much aware of it.
Thanks.
That's great. Well, there is in the chat now information on current and past sessions in our COVID series. So the link is there. You'll have to scroll up just a little bit to find it. I'll just highlight a couple of things that we have, well, that are coming up, not just from OCAL. Kevin's already mentioned this, but I'll mention it again. The Workplace Health Without Borders has a webinar on Monday, July 31st on filtering face piece respirators, so i.e. N95 and the similar ones. That's at, I believe it's at 10 a.m. Eastern, but if you go to the Workplace Health Without Borders, just Google that and you'll be able to find that quite easily, or scroll up. Kevin's got the link in there directly. OCAL is hosting a World Cancer Day webinar on Friday, February the 4th, Needles in the Haystack, Rare Cancers in the Workplace and Tools to Prevent Them, from 10 to 12. That's Friday, February 4th. Our next COVID will be Friday, March 4th, so stay tuned for that. That will be on mental health in the workplace, which is a very important topic right now, as that has been a stress for a lot of people. So watch for that. Thank you everyone for coming. Thank you to our speakers and our pre-recorded speakers for coming. And don't forget to do the survey. It'll be coming out very shortly. Please do that. We use that to plan our future meetings and to gauge what topics we should do going forward. So please fill that short survey out. Thank you everyone so very much for being here today. Have a great rest of your Friday.